Hi, my name is Bethany Everett. I'm a P4 student at Texas Tech School of Pharmacy in Abilene, Texas. This is my pediatric in-service presentation, which I'm doing over the potential of Prolia for treatment of osteogenesis imperfecta. I came up with this topic when I was in clinic with my preceptor and a pediatrician. A patient came in who had osteogenesis imperfecta. Their insurance had not been wanting to pay for their bisphosphonate infusion therapy for about a year. So this patient had been without treatment for over a year, and I asked my preceptor if there was any data in Prolia with osteogenesis imperfecta. So I got to look it up, and so that's what I'm presenting over today. So we'll go over the epidemiology, etiology, pathophys, signs and symptoms, diagnosis, current treatment. We'll look at this small little article that I found. There's not a whole lot of data with Prolia and osteogenesis imperfecta. The study that I found was published in 2014, but I know now there are at least two larger clinical trials that are ongoing right now that will have a little bit more data on a larger scale in a couple more years. So we'll look at those as well. So, epidemiology. Osteogenesis imperfecta is a rare disease with a suspected incidence of 1 to 20,000. About 80% of patients with OI have a genetic mutation that affects collagen. The genetic mutation follows a dominant mode of inheritance. And if we break down the word osteogenesis imperfecta, osteogenesis, osteo is bone, genesis means to make, and imperfecta obviously means imperfect. So this is a disease of making imperfect bones. Looking at the pathophysiology, just a refresher, bones are made up of a framework of the protein collagen with a mineral called calcium phosphate, which is what makes it strong. So the collagen is the framework, and then the calcium phosphate is what makes it strong. Most mutations are in collagen 1A1 or collagen 1A2 genes. A couple suggestions are that there may be a loss of function mutation, like a stop mutation, which results in a reduced amount of collagen, but it's normal quality collagen. Other mutations can lead to a qualitative alteration in collagen, which leads to inadequate stability of the collagenous portion of the bone, and that stimulates bone resorption because it's not as sturdy, it's not as strong, so the body tries to break it down and make new stuff. Which results in this high turnover osteoporosis-like state. Some signs and symptoms. So collagen is one of the most abundant proteins in your body, if not the most. So we're going to see skeletal symptoms and extraskeletal symptoms. Skeletal symptoms are going to be decreased bone mass or reduced bone stability, increased fracture rates, deformities of the vertebrae, potentially like scoliosis. These patients are going to have a short stature, and most of which will receive growth hormone earlier in their life to help them have a little bit of height to them. And we can also see disproportionate extremities. Extraskeletal symptoms, we can see hypermobility of ligaments, increased fragility of vessels and heart valves, early hearing loss, a blue-gray discoloration of the sclera, so the white part of the eye, and we can even see some brittle teeth. Diagnosis is usually made early in childhood, and it's based on clinical symptoms and history. We'll look at x-rays, do a DEXA bone density scan, and we can even do a blood test and look at the DNA and check for the genetic mutations known in OI. Current treatment, we really have three main categories of treatment. We have bisphosphonate therapy, so pharmacologic therapy. We have surgical treatment, and then we have physiotherapy. So just a little review of bisphosphonate mechanism of action. They bind to hydroxyapatite crystals of the bone, which are then reabsorbed by osteoclasts and the bisphosphonates induce osteoclast apoptosis. So they effectively reduce bone reabsorption and therefore increase bone mass. For surgical treatment, we see bone support with intramedullary rods. There is a picture of an x-ray and a couple slides later that I'll point out an intramedullary rod. And we also do physiotherapy for patients with OI. So these patients will have muscular hypotonia and weakness of the tendons and ligaments. So strengthening these muscles induces a bone growing stimulus, which can increase their bone mass by inducing synthesis of extracellular matrix by osteoblasts. So this is getting into the little journal article I found. It was done in Germany, and it was published in 2014. Now it's a really small scale study. There's 4 patients, but this was really one of the only journal articles out there. But I know right now, like I mentioned, there are at least 2 large clinical trials going on right now that will have better data in a couple years with. So I'm working with what we have right now, but we'll go over Prolia, or generic name is DENOSUMAB. We'll go over its mechanism action. We'll look at a little bit of the background and patient population. We'll go over the interventions that was done in this study. We'll look at methods they used to evaluate the efficacy of Prolia, and then we'll go through the results. So Prolia, the mechanism of action, it's a rank L inhibitor. So it inhibits osteoclast formation, function, and survival. Osteoblasts secrete rank L, and this rank L activates osteoclast precursors and subsequent osteolysis. So denosumab binds to rank L, which blocks the interaction between rank L and its receptor rank, and it prevents the osteoclast formation, leading to decreased bone reabsorption and increased bone mass. So I wanted to point out there's a different mechanism of action than bisphosphonates here. Bisphosphonates are taken up by the osteoclasts and then inhibit their function and induce osteoclast death, but Prolia works by preventing osteoclast formation and activation. So essentially Prolia works kind of a step ahead, if you will, of bisphosphonates. A little bit of background. So I mentioned before that there were mutations in collagen in most patients. In this patient population specifically, they noticed a mutation in the SERPIN1F gene, and this SERPIN1F is a gene that codes for pigment epithelium derived factor, or PDEF, which this PDEF is not detectable in patients with OI serum. And PDEF inhibits osteoclast differentiation and hence bone reabsorption by osteoprogerin and receptor activator of NF-kappa B, or rank L. Remember that rank L is what is inhibited by Prolia. So essentially, this is kind of a targeted therapy for this specific mutation. This subgroup of patients are affected by an increased bone reabsorption and are known to have poor response to bisphosphonate treatment. So this patient population, I mentioned earlier, it was based in Germany, and there were 4 related boys with OI. They had this specific gene mutation. They were all on previous IV bisphosphonate therapy with poor response. Their spine x-rays revealed multiple fractures and deformity, and all of them were dependent upon a wheelchair. So for our interventions, Prolia was given 1 milligram per kilogram sub-Q injection every 12 weeks. After 1 year of the every 12-week cycle, patients were allowed to have a shorter interval of a minimum of 10 weeks based on the recurrence of skeletal pain and increase of osteoclastic activity after measuring their urinary DPD excretion. And I'll go into a little more about what that is, I think, in the next slide. So they were also supplemented with oral calcium and vitamin D based on weight, and the calcium and vitamin D were given for 2 weeks after each injection. So for the methods of measuring efficacy, we did a dual X-ray energy absorptiometry scan or DEXA scan of the lumbar and total body, and then aerial bone mineral density, which were transformed to age-specific Z-scores. So a reminder of the difference between Z-scores and T-scores. A T-score is comparing a person's bone density to that of a healthy 30-year-old of the same sex, and a Z-score is comparing that person's bone density with that of an average person of the same age and same sex. And we also looked at the urinary DPD excretion, which was used to quantify and monitor inhibition of bone reabsorption. So DPD is a byproduct of type 1 collagen, which is found in bone, and the urinary DPD test is used to measure how much the rate of bone reabsorption. So a high DPD value means that there's a high rate of bone turnover. We also looked at lateral x-rays of the spine, and they were evaluated by the same radiologist to mitigate bias, and they calculated the projected vertebral area of the lumbar vertebrae. We also did 2 different mobility assessment tests, and other labs that were followed are osteocalcin, parathyroid hormone, vitamin D, and total serum calcium. Looking at the results, so I mentioned all these 4 patients are related. They all have the mutation in the SERPIN1F gene previously mentioned. We can see that from this table that patients were ages 9, almost 7, almost 6, and 18 at the beginning of treatment with Prolia. They had all received prior bisphosphonates therapy, and you can see the duration of treatment there. We can see their height at the beginning and end of treatment with Prolia. Patient 1 grew 8 centimeters, patient 2 grew 5 centimeters, patient 3 grew 6 centimeters, and patient 4 did not grow at all, but since they were already 18 years old, they probably already reached their adult height. Looking at the BAMF and GMFM66 scores, all of the scores increased over the treatment period with DENOSUMAB. So those were the mobility scores, and even though all the patients are confined to a wheelchair, unable to stand, walk, or jump, so an improvement in these mobility scores is really outstanding and really important because they didn't lose mobility over time even though they're physically disabled. Patient 1 and patient 2 both sustained fractures, but it was noted in the article that they sustained mild trauma, but it wasn't specified what exactly happened, whether it was a car wreck or whatever. Patient 3 and patient 4 do have some missing data. This was noted to be because they returned home to their mother country for nearly a full year. So that's why some of the results are missing, which is unfortunate. Looking at the aerial bone mineral density, these first 2 columns are the beginning of the and final bone mineral density of the lumbar spine. And then in brackets, we can see their Z-score. So in patient 1, we can see an increase in bone mineral density, and same for patient 2. We can see an increase in Z-score in patient 1. And just a reminder, Z-score, or for a normal healthy bone, T-score is -1 and above. Low bone mass is from -2.5 to -1. And extremely low bone mass is less than -2.5. So in patient 2, we see a large improvement in their lumbar Z-score from -4.3 to -2.5. And then looking at aerial bone mineral density, this was considered their whole body minus their head, so not their skull. But we can see in patient 1 an increase in bone mineral density. In this one, we don't see an improvement in Z-score, which is unfortunate, but in all the other ones we do see an improvement in bone mineral density and an improvement in Z-score. Except for patient 3, we just see an improvement in bone mineral density, but no improvement in Z-score. It stays the same. So I did want to note that in this case, instead of looking at a Z-score and comparing that bone mineral density to another child of the same age and sex, I think it would be better or maybe more accurate to just have the raw data and not necessarily compare it to other children. Even though there was an increase in bone mineral density, but there's a decrease in Z-score, it's kind of misleading to which one, is it more important to have an increase in bone mineral density or an improvement in Z-score? So as I mentioned earlier, DPD is the substance found in type 1 collagen in bones, and the urine DPD test measures reabsorption rate of the bone. So a high DPD means high bone turnover. So in patient 1, we can see day 1 after their injection, we see an elevated DPD. After 2 weeks, we can see a decrease in urine DPD. At day 28, we see another increase in DPD. And that's kind of the standard pattern that we see. Initially on day 1, we'll see a higher DPD, and then it will decrease over time. So that means that with Prolia, with treatment with DENOSUMAB or Prolia, we do see a decrease in bone turnover rate, which is awesome to see. Spine morphology. So I'm going to preface the slide by saying I'm not a radiologist. I've never been trained to interpret any type of x-ray. But the author said that there was an improvement in morphology, so I'm going to take their word for it. But as I mentioned earlier, I would note that you can see these intramedullary rods in their femur. But even I think I can notice, looking at patient 2 from the start to after 2 years, I think I can see that there's an increase in their vertebrae thickness, and they look more dense to me. And they also look less compacted or more compressed and like more evenly spaced, even though they're sitting in a wheelchair the whole time and suffering that bone compression. Looking at safety and tolerability, there were no severe side effects reported. Injections were well tolerated. There was a decrease in serum calcium concentrations after each injection, but this was compensated by the oral calcium supplementation that the patients had to take. There was no increased rate of infection, and the patients actually reported reduced bone pain after receiving their injections. So, discussion and conclusion. The urinary DPD excretion shows suppression of bone resorption. An increase in areal bone mineral density was observed, and spine morphology was improved. Mobility improved also, despite the patients being wheelchair bound. Again, patients reported reduced bone pain after receiving their injections, and then they noted that it recurred at the end of each treatment cycle, so when it was time for their next injection. And further clinical trials are needed to compare the effect of therapy with bisphosphonates and denosumab in OI. As I mentioned earlier, there are at least two that I know of, current ongoing clinical trials that are larger scale, obviously, than 4 patients. But they're estimated to be done in November 2023 and January 2022. This NCT followed by the numbers, that's their clinical trial identifier numbers if you care to look them up. And there are my references. So if you have any questions or concerns or comments, that's my email address, so feel free to reach out to me. Thank you for listening.